We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, welcome to The Pinch of Salt, a podcast brought to you by the ERA. I'm your host today, Dr. George Kosmadakis, and the subject is inhibition of aldosterone synthase and MRAs in nephrology. Aldosterone has been recognized as a key hormone driving not only fluid balance and blood pressure, but also inflammation and fibrosis, thereby fueling CKD progression and cardiovascular risk. Mineralocorticoid receptor antagonists, such as spironolactone and eplerenone, have shown clear benefits, but their use has been limited by the side effects, particularly hyperkalemia. The development of newer non-steroidal MRAs and the investigational aldosterone synthase inhibitors has opened a new chapter in the therapeutic arsenal of nephrology. To discuss these exciting developments, we are joined today by our distinguished guest, Professor Maria Jose Soler Romeo from Barcelona, Hospital de Hebron, Spain. Pepa, Professor, welcome to the Pinch of Salt.
Dear Dr. Kosmadakis, thank you very much, and thank you to the European Renal Association for the invitation. It is a real pleasure to join you today.
Well, the pleasure is all ours, and thank you for the honor to be with us today. I will start straight away with the first question, which is always the most naive one. Why is aldosterone such a central player in CKD progression and cardiovascular complications?
This is a really good question. Actually, aldosterone is not only a regulator of sodium and potassium balance and blood pressure, as you already said. It is a powerful mediator of inflammation, oxidative stress, and fibrosis. In both the kidney and the cardiovascular system, excessive activation of the mineralocorticoid receptor promotes structural damage, endothelial dysfunction, and tissue remodeling. So this effect contributes to proteinuria, progression of chronic kidney disease, and an increased risk of cardiovascular events. So aldosterone, therefore, represents a key mechanistic link between kidney disease and cardiovascular complications. So it's a cardiorenal hormone.
A cardiorenal hormone. So it is a key player of the evolution of CKD and cardiovascular complications. So we have a target. And how do mineralocorticoid receptor antagonists might fit into the current treatment strategies for CKD? There is a revolution today. What is the place of these antagonists in the current treatment strategies?
Is there a place? And for years, we have been using this mineralocorticoid receptor antagonists in the treatment of heart failure and hypertension mainly. Mineraloreceptor antagonists are an important really component of add-on therapy to the standard renin-angiotensin system blockade. Actually, the classical ones, the steroidal ones, spironolactone and eplerenone, have shown clear benefits in terms of heart failure and reducing proteinuria and cardiovascular risk. But their clinical use has been not clearly the positive effect demonstrated in long-term clinical trials in the terms of chronic kidney disease progression, and there have been limited also for the use in patients with chronic kidney disease for the adverse events, mainly related to hyperkalemia and endocrine-related side effects, such as gynecomastia. But more recently, there have been new studies, and there have been new non-steroidal mineraloreceptor antagonists created and demonstrated a positive effect in terms of chronic kidney disease progression with the finerenone. The studies published in 2020, 2022 demonstrate clearly Fidelio and Figaro a positive effect in terms of decreasing, delaying the progression of chronic kidney disease and the cardiovascular events. And this is not the only one. Currently, we have a new one named by Renal that is on a study, and recently a phase 2 study named Miro also demonstrate a positive effect in terms of reducing proteinuria in patients with chronic kidney disease. So now we have a new drug for treating our patients, and the positive part is that the hyperkalemia secondary event or adverse event with this drug is lower as compared with the classical steroidal mineral receptor antagonist. So we have drugs that works in terms of key cardiorenal protection with a lower number of secondary events. So we are happy in diabetes and in chronic kidney disease because for years we only had the renin-angiotensin system blockade to delay, slow the progression to chronic kidney disease, and we are in the era with a new drugs coming.
Yeah, that's wonderful. And we were very excited with Fidelio and Figaro and Fidelity, which was the meta-analysis of the two studies of finerenone. And we are very excited that there are newer agents that are in advanced stage of production. So do you think that there's a potential of these novel aldosterone synthase inhibitors compared to traditional MRAs, and what is their place in the paradigm of CKD treatment algorithms?
There is no doubt, and the CKD algorithms have been changed from 2020 a lot. For years, we didn't have a KDIGO update from 2012 to 2020, and now with the new drugs, the KDIGO should be updated for the treatment of patients with chronic kidney disease and diabetes, or including chronic kidney disease. So nowadays, these now drugs, finerenone, has been accepted as is in the first line with SGLT2 inhibitors and GLP-1 agonists to delay the progression of chronic kidney disease in the majority of the algorithms in patients with chronic kidney disease and diabetes. We have not yet the results of the FINE CKD study. I think that this year in the ERA we will have in the late breaking clinical trials of the abstract, we will have the results of this study that is studying the effect of finerenone in patients with chronic kidney disease, albuminuria, but without diabetes.
Right. So it is a very exciting period to be a nephrologist.
Sure.
since 10 years we are very happy to be nephrologists. And that would be my last question, medical question. What are the challenges and the future perspectives? I'm talking about probably other aldosterone synthase inhibitors, other kind of treatments that are addressing aldosterone synthesis. What are the future perspectives and the challenges for the everyday nephrology practice? What is the future?
The future is bright. I foresee the future for the nephrologist is bright. And if I was born again, for sure, I will choose nephrology because I enjoy to be a nephrology. I have no doubt. So now, not only we have the non-steroidal MRAs, if not, we also have in a study the aldosterone synthase inhibitors. This is a further step forward because they block aldosterone production directly rather than antagonizing the mineralocorticoid receptor. Several novel agents are under clinical investigation, including baxdrostat, lorundrostat, and vicradostat. So we are happy of that. Actually, baxdrostat has shown significant blood pressure reductions in patients with resistant hypertension and high selectivity for aldosterone synthase, with minimal impact on cortisol synthesis. Lorundrostat has also demonstrated consistent suppression of aldosterone levels and blood pressure in phase 2 studies, and vicradostat has been evaluated in patients with chronic kidney disease, where it significantly reduces albuminuria on top of the classical renin-angiotensin system blockade and SGLT2 inhibitors. So we also have a renoprotective effect. Where you are talking about the challenges in the future are high, because now the question will be, which is the drug that I should start earlier for protecting my patients with chronic kidney disease. In that setting, a new study named Confidence that mixed SGLT2 inhibitors and finerenone have shown a potential effect in terms of reducing proteinuria in patients with diabetes and chronic kidney disease, and a safe demonstrate that it's safe to start with the two drugs together. So for nephrologists, we are having the 4-5 pillars, like the cardiologists and our patients with chronic kidney disease and diabetes and proteinuria. We will have to choose how to start, but for sure start early and be sure that we implement all of the new strategies for avoiding the progression to end-stage chronic kidney disease. So if we could avoid or delay the progression to dialysis, for sure, this is really important, because we will save money and we will improve the quality of life of our patients.
Yeah, we are listening lately to terms that looked crazy since a few years, like CKD remission. It's as if there is a magic combination of solutions that is completely stopping the progress of CKD in certain patients. It's a very exciting. Yeah.
I think that yes, you can stop the progress of the CKD in patients, and we thought that albuminuria we were not able to reverse, but we are facing that we can reverse from macro to microalbuminuria. Actually, we do not name anymore macro and micro, because the size of the albuminuria is the same, and we name albuminuria degree 3 to albuminuria degree 2, but including we can disappear. So now I'm facing that I'm treating the patients in my clinics, in my outpatient clinics, and I'm discharging them to the primary care, because they become normal albuminuric and the kidney function, they will not end up in dialysis. So this is really nice moment for our patients. So we will have to make an effort, and the effort will be to detect and diagnose the patients with chronic kidney disease, because as all of the nephrologists know, the kidney disease is a disease that is silenced, and you do not feel anything if you have albuminuria or your GFR or you have renal chronic kidney disease with GFR lower than 60. So now is the moment to detect the patients that are at risk and to screen them from chronic kidney disease.
So that is the aim of this podcast, is to pass the word, and we hope that people will be much more sensitized to this. Wonderful. So now, Pepa, I will ask you the most difficult question, which is the personal one, and we ask everybody about this. If you were in a desert island, which book, luxury item, and 2 songs would you take with you?
Okay, really good question. For a book, I will choose The Physician by Noah Gordon. That is a novel that combines history, medicine, and adventure. And for sure, one of the novels that make me to go through medicine.
Okay.
My luxury
Beautiful.
item will be the one that I'm wearing today. That is a family necklace. So my mother prepared, and we are 3 siblings, and all of us has this kind of roll with the name of us inside. So I will take that because this will be remembering my family, and I love them a lot. And if I have to choose 2 songs, I love a lot of songs, Spanish, non-Spanish, but one of my favorite singers is named Joaquin Sabina. He's already retired, and I had the opportunity to go to his last concert here in Barcelona. And the song will be Amor se llama el juego, that in English is Love is the name of the game. And for the second one, I will go for Leonard Cohen, that I like a lot him. And I also had the opportunity to be in a concert with the family with him. And I will choose I Am Your Man.
Pepa, Leonard Cohen is very popular among the nephrologists. We are doing a playlist every year, and he figures every year in the playlist. So I think he has something about sensitizing the nephrologists. I don't know.
Maybe, I don't know. But the one that used to listen and to play to me Leonard Cohen, it was my father. He used to put
Right.
that in the car when we were going to a long travels. And I think that was for my father that I love Leonard Cohen. And actually, we all of the family went to, I think that Leonard Cohen at that time was 72 or something like that years old. And we were all together to the concert, and we enjoy a lot.
Oh, wonderful, wonderful. So, dear colleagues, as you can see, targeting the renin-angiotensin-aldosterone system continues to evolve, with MRAs and aldosterone synthase inhibitors offering a renewed hope for patients with CKD. These therapies may allow us to reduce progression, improve cardiovascular outcomes, and personalize the care. We hope this podcast has shed light on the opportunities and challenges in this field. We hope you enjoyed the discussion as I did. Pepa, thank you very much for being with us today. It was very kind of you.
Thank you again for the invitation. It has been a pleasure to discuss these developments in nephrology with you. And I look forward to being with you in another podcast in the future.
That will be a pleasure, really. So, dear colleagues, stay tuned for more episodes of The Pinch of Salt available on all known platforms. Take care of yourself. Please, thank you for listening us today. Bye.